metastasis.
Okay. So, it has been a very interesting meeting until now. I hope I'll be able to keep up. I will mainly look a little bit at bone protection and live with those issues because I think the other parts of treatment is at the moment quite clear and standard. But the problem is quite evident with bone metastasis. It's all about quality of life. You've got pathological fractures that require surgery, radiotherapy. So there is an important issue in all of this. And as you've already shown before, it is very frequent in prostate cancer as compared to other sites. As you can see here, bone and then distant lymph nodes is about 10%, and the rest is decreasing in frequency. So the first thing we should be aware about if we want to protect the bone is also when do we start androgen deprivation therapy. And if you look at the ERTC trial 3891, then there's only a small population that really profits of immediate androgen deprivation, and this population is mainly characterized by a high PSA and a short PSA doubling time. And I think before we engender on hormonal treatment, which has an impact on bone, then it should be well balanced for its benefits and its potential non-benefits. Because androgen deprivation therapy, as we've already discussed before in this session, has many adverse effects, and mainly also on the skeleton with a decreased bone mineral density, an increased incidence of osteoporosis, and also potentially fractures, apart the others that you all well know that we discussed. And we know that if we treat patients with LHRH agonists, this clearly decreases bone mineral density in men with prostate cancer. And thus, if you see control and those under the agonists, we have a clear decrease. And this was without any concurrent in vitamin D and calcium. Again, over time, there's also time, which is important. If it's less than 1 year, it's not that strong risk factor, but if we give it longer on, that is something to bear in mind as we discuss when, and there's also one argument more in favor of intermittent androgen deprivation therapy. The risk fractures, again, just as in a series, any fractures in this series, it's about an increase of 50%, and the hospitalization rate for fractures is clearly higher in patients under androgen deprivation therapy. And this was also substantiated in the study by Fred Saad in these patients. And there is a risk of bone metastasis. So what can we do? And what do we do? If we look at the numbers, we're not doing too well. 50% of patients will suffer from osteoporosis if treated with androgen deprivation therapy, and the promotion of healthy bone behaviors, so that should we do something, is very poorly implemented at initiation of androgen deprivation therapy. Finally, our current recommendations do not include any hints or any proposals for the addition of an osteoclast inhibitor therapy, be it a bisphosphonate, be it a rank ligand inhibitor, in men without bone metastasis treated with long-term androgen deprivation therapy. There's hardly any calcium and vitamin D supplementation, and it is very poorly studied at this moment in time. In this large health system-based study, you can see we have here breast cancer, lung cancer, and prostate cancer. I'll just concentrate on this, but you see a general tendency that very few people get bisphosphonates. It's only about 20% who receive bisphosphonates in this long-term follow-up, and that is about half prior to a skeletal-related event, and the other half after the skeletal-related event. Although we know that we have an effect, alendronate, simple bisphosphonate, has a clear impact on bone mineral density at 12 months in patients undergoing androgen deprivation therapy. Other compounds, more reason. Zoledronic acid clearly has an effect in this Cochrane database systematic review, and also denosumab in the study by Smith clearly has an impact on bone mineral density. So it is something to bear in mind in these patients that are getting on hormonal treatment, to at least upfront give them some bone blocking treatment. I can say here, I didn't say it before, I have nothing to disclose. But it's an important issue to think about, that these patients might in the long run profit, because osteoporosis is not fun either in the long term. If you look at treatment, hormonal treatment can vary a little bit. Standard androgen deprivation therapy, and zoledronic acid. This is intermittent androgen therapy, and this is intermittent androgen therapy with zoledronic acid. And they looked at patients who have a normal or low risk of developing bone metastasis, and those that are at high risk, which is defined with age, over ICSI, a history of fractures, diabetes, alcohol, and smoking. And as you can clearly see, that in patients probably with low-risk intermittent androgen deprivation therapy combined with bone protection will have an impact on the incidence of vertebral fractures. The interesting thing is that patients at high risk, even with intermittent androgen therapy, we do not gain that much, but that might be something to follow up more. Easiest would be to not have to give a drug, so exercise might be an issue. There have been some recent studies on this, but it's a growing field and hasn't been very much done yet. There is an effect in some patients, but this was out of a non-randomized study that showed that resistance training, so pressing against the resistance, for example, may help attenuate the androgen deprivation-induced decline in bone mineral density, but there's no long-term studies. And there's also one of the conclusions of this study by Gartner is that there must be investigated different types of exercise that might work, and eventually the combination with pharmacotherapy or dietary supplement treatment. In this recently published study by Cormi, they looked at the short-time exercise during the first 3 months of androgen deprivation therapy, and their study, there was a clear decline, as to be expected, in bone mineral density, but in this short period of time, the training program did not attenuate the decline in bone mineral density. So their conclusion was, excuse me, that there might be long-term studies to be done, and we also have to look at what kind of exercise, again, should be used and proposed. Now, let's move on to what happens to bone, again, when we remove androgens. And if you look at this old study, sort of old study by Rob Pelgers from the group of Leiden, they looked, a simple thing, they looked at alkaline phosphatase and looked what happened, the level before orchiectomy and 1 month after orchiectomy. As you can see, those who have a normal alkaline phosphatase, they do better than those that have an increased levels of alkaline phosphatase. And bear in mind, these were patients who did not necessarily have overt bone metastases. And so interestingly, one of their conclusions was that there might be a serum alkaline phosphatase flare after orchidectomy that might be the first indication of widespread micrometastases. And this might further validate studying this more upfront. Do we have to treat earlier? Because if these will then do bad over the next couple of months, we might be able to interfere earlier. And this has also to do with this vicious cycle between the tumor and the bone, namely the osteoclasts that get stimulated over the osteoblastic response. And taking that into account, that has also some biology behind it. If you have a low bone turnover and you have these bone multicellular units, you have the osteoclast moving in, breaking down bone, you then have the osteocytes moving in and depositing bone, and then these osteoblasts, and then they become osteocytes and you have bone deposition. So if you have here some tumor cells because these osteoclasts, they release growth factors from the bone when they move in. And so if you have a high bone turnover, the chances that one of those micrometastases might be turned on and might be develop more bone metastases might be an issue. Earlier studies going back to 1994 of ours showed that in an animal model, the castrated animals developed more bone metastases, most probably due to an increased bone turnover. Now, taking, again, in the animal setting, because that's easier, if you're radiography, you have this optical imaging where the bone metastases light up. And if you give the bisphosphonate treatment, in this case, in these PC3 tumors, after you've injected into the left ventricle these tumor cells, they've been circulating for some time. You see, if we give placebo or the bisphosphonate in this case, we have a slowing of the growth of the bone metastases, of the number of metastases, and also they become radiographically evident much later. However, if we turn it around, those animals, if we first inject the bisphosphonate and then the tumor cells, you can see and compare that it takes much longer for the bone mets to develop, and there's also a lower number of bone mets as compared to control. So there is some interest in this, and this might be followed. We have to go, if you go back for a long time, you might say so, if you look at the MRC trial looking at cladronate versus placebo in patients with metastatic disease, you can see that there's not that much symptomatic bone-free, progression-free survival, but nevertheless, on the other side, you have an improved WHO performance status. But an interesting finding, and that was what already Professor Schäfer alluded to, although there was not much of a disease-free difference, there is some overall survival benefit in these patients receiving cladronate, be it for the lack of pain, and interesting enough, which would be an argument against early treatment, not in those patients with localized disease, but maybe as we have to wait long here, this might turn out, if patients survive long enough, to have an advantage. Again, it's mainly the patients who have a poor performance status, who suffer, who profit, and it's mainly the patients with metastatic disease who profited from this bisphosphonate. Prevention of bone metastasis, there are many studies ongoing. There's one ongoing in prostate cancer, the Zuoz study with using zoledronic acid. The data is still being collected, but it'll take some time until we have the final answers, because it'll take time in this population to develop bone metastasis and skeletal-related events. But there is some indication out of some of the early systemic treatment studies in breast cancer that there is an incidence that the incidence of skeletal metastasis can be significantly lowered, even by giving a simple bisphosphonate such as cladronate in these patients. Treatment, you all well know, there is a difference. Zoledronic acid, 4 milligram, has done and shown its effect, and it clearly decreases bone pain over time. Patients who receive zoledronic acid have less pain than patients on placebo. The same is true for denosumab. We have this randomized trial in the Lancet 2 years ago, 1,400 patients, randomized half-half, and there was a significantly increase in bone metastasis-free survival by a median of 4.2 months. They also delayed the time to first bone metastasis by, again, almost 4 months, and as to be expected, overall survival, at least in this short-term study, did not differ, and the rates of serious adverse events were similar in both groups. But the ONJ was 5% with the denosumab, and there was a 2% hypocalcemia rate in these patients. Then the study by Fizazi comparing the two, zoledronic acid versus denosumab. We have a clear advantage of denosumab in the long run, also the cumulative mean number of skeletal-related events per patient, but they do both have an effect. and again, overall survival, ultimately time to disease progression are not altered by the two treatment options. Again, side effects, differences were found in fatigue, a little more in favor of zoledronic acids, grade 3-4 adverse events, a little bit more in favor of zoledronic acid, and also for hypocalcemia, which was a little bit lower with zoledronic acid. So this was confirmed in a rather more phase 4 study, but here the difference in everyday life was not that strong, but it's there. So if someone does not stand or cannot handle denosumab, you might be happy with zoledronic acid, and that might be changed and can be changed and might be of use for the patient. So in conclusion, bone health starts when considering androgen deprivation therapy and using these bone-seeking agents like zoledronic acid and denosumab can prevent loss of bone mineral density by androgen deprivation therapy and decrease skeletal-related events. There is a slight favor for denosumab over zoledronic acid, and if we will be able to prevent the development of bone metastasis, it still needs to be shown. But I'm sure if you looked at what we learned in the meantime about the vicious cycle, then there's much more going on in the bone than there's just this simple cycle. And so I think by learning more about the effect of these different factors, we might be able to interfere with bone metastasis better in the long run. So thank you for your attention, and I'm ready for any questions.
Yes, thank you, George, for this nice presentation and overview of protection of the bone under the hormone therapy. Are there any questions from the audience? Yes.
Thanks. Nice talk, George. Any place for fighting the inflammation?
Fighting inflammation.
Because I guess there must be, by definition, quite a lot of reaction and inflammation at the side of the bone deposit. There must be a fight. So by definition, the immune system is part of it. So,
looking at a recent publication in Cell, where what we know from the review of Feldman some years ago, that giving steroids might not be advantageous in these patients because the steroid can also activate at one point the androgen receptor. So we'll have to see. Non-steroidal anti-inflammatory drugs won't have to try, but if you look at the results from the Stampede trial, there's no advantage of celecoxib in this setting. So we have to find a better anti-inflammatory drug. So it's difficult to.
Any other questions? When you start with a bone protection therapy with denosumab or zoledronic acid, do you perform a bone density measurement before you start? And how do you monitor the therapy?
Well, therapy, you repeat bone scans or your MRI, whatever imaging you use. It's sometimes a question of costs. So if you have an osteoporosis proven by osteodensitometry, the healthcare will be obliged to cover the costs. Whereas if you do not, or you do not have proof of osteoporosis up front, they might fight you. So in patients where I see I don't have overt bone metastasis, they're at high risk, I often do a bone mineral density to be able to cover the costs, but that's more.
Who perform a bone density measurement? Okay. And you don't mention the side effect of the necrosis of the jaw. It is very rare, but it is very painful for the patient.
Well, it's there. You cannot deny it. It's showed it was 2% for zoledronic acid. It's a little bit higher for denosumab. That's why it's important to send your patient to the dentist first and contact his dentist and see what he thinks, if it would be able to acceptable for him to do it, or have him get his teeth in order before. So you usually can buy that much time.
Any other question? Yes.
My question from before: patient with significant bone metastasis, will you start anastomotic or hyaluronic acid right away, or will you wait until he gets castration resistant?
If he has overt metastases, you will start hormonal treatment as well, usually. So in that case, I would start him also on bone protective treatment, because you'll kick on bone turnover by castration, and that might facilitate the take or the progression also of the tumor. So I would start with it.
Any other questions?
Okay.
Yes.
You began by showing the green spot on paper of aletronate, which improves bone mineral density in men on EBT. We actually did the same trial and showed the same thing in Canada. Maybe that's what influenced me, but not many people use the oral bisphosphonates, which is one pill once a week with no osteonecrosis of the jaw, for osteoporosis prevention. And to my mind, we should be using it a lot more. The data is it likely doesn't prevent bone mass. So I think the more powerful bisphosphonates have a role once the patient has metastatic, or especially hormone refractory metastatic disease. But during that long period of hormonal therapy before castrate-resistant metastatic disease, I think we should be using much more of this. They develop osteoporosis, not a good thing. You can prevent it with a single pill once a week, which is generic and cheap and relatively non-toxic. So
I agree completely. You don't have to necessarily give zoledronic acid, or Prolia as an injection. You can also put them in Engadin, for example, which is once a week. But you have to beware, because there's two forms out, or two brands out there, and one is only accepted for osteoporosis and the other is only accepted for bone metastasis. Now, if you prescribe the wrong one for bone metastasis, at least in our healthcare system, they hammer you and say, we're not going to pay it, despite it. It's not that expensive compared, because, I mean, 3 months is about 600 francs, so compares easily in terms of prevention. But I agree completely, we should be using it more easily.
Okay. Thank you very much. We will finish this session and we will